this morning. I'm Ava Kadiwada. I'm one of the chief medicine residents this academic year. And this morning I'm welcoming Dr. Carpenter and Dr. Mudd to internal medicine grand rounds. Dr. Carpenter is dual board certified in emergency medicine and internal medicine, professor of emergency medicine here at WashU. And he serves on the Society for Academic Emergency Medicine Board of Directors, as well as the American College of Emergency Physicians Clinical Policy Committee. His research interests include diagnostics, dementia, fall prevention, and implementation science. He is Deputy Editor-in-Chief of Academic Emergency Medicine and Associate Editor of the Journal of the American Geriatric Society and Annals of Internal Medicine's ACP Journal Club. He co-led the collaboration to develop the American College of Emergency Physician, American Geriatric Society, Geriatric Emergency Department guidelines, as well as the Equator Network standards for reporting of implementation research, reporting guidelines. Dr. Mudd is an assistant professor of emergency medicine at WashU in St. Louis. He has a background in basic and translational immunology, and he studied T-cell responses to AIDS viruses during his PhD studies at the University of Wisconsin. He currently studies the early immune response to influenza and SARS-CoV-2 in human patients infected with those viruses. Dr. Mudd completed his emergency medicine training at the University of Cincinnati and is board certified in emergency medicine. While he spends the majority of his academic time pursuing translational research, he also practices clinically in the Barnes-Jewish Hospital Emergency Department and the Barnes-Jewish West County Hospital Emergency Department. Today, the two will be discussing COVID-19 diagnostics and treatment research based in ED insights. Thank you for joining us this morning.
Thank you, Eva, for the warm introduction, and thank you to the audience for joining us today. It's been 18 years since I was chief resident of internal medicine, and time certainly flies. So how do I get this slide to change? Looks like it's working now. So I just have some disclosures of relationships. I am the journal editor, as was discussed, and I'm going to be discussing some of the articles in our journal. I'm also on the AGSF Clinical Policy Committee and the SAAEM Board of Directors, as well as the Leadership Core for ClinStar. I do have some research disclosures. My funding is primarily in geriatrics. I also help out with the Sickle Cell Network research grant here at WashU, and I serve on a couple of speakers bureaus, one of which I'll mention later in the lecture. So COVID-19 is a topic that we've all probably heard too much about in the last 8 months. We wanted to walk you through our experience in the early months of COVID, basically in April and May, trying to figure out an evidence-based approach to diagnosing COVID, to understanding the biases in the literature that was coming out early, and some of the probing that we did to really understand those biases and the implications for clinicians, both clinicians in emergency medicine, internal medicine, critical care, infectious disease. And I also, while I'm painting this picture for you, want to give the Department of Internal Medicine a resource to use for diagnostic accuracy research, and to show you the process that we've developed that we were able to really adapt and take advantage of in the early months of COVID. And then I'm going to turn it over to Dr. Mudd, who's going to talk about some of his immunology research and the implications of that research for treatments for COVID. So we'll start with the scenario. 45-year-old taxi driver, no significant past medical history or past surgical history, takes no medications, tries to wear a mask when he's in his cab, but has lots of clients in there every day that are coughing and potentially sick. He comes in because he's got a fever and he's concerned about COVID-19. You can see his vital signs there. He's a little on the tachycardic side, saturating just fine, no respiratory distress, but he is febrile. What's your next step? Whether he walks into the clinic or the emergency department, urgent care, what COVID testing do you send? Do you send COVID testing? Do you need other labs? Are those other labs going to be helpful to help roll in or roll out COVID? What about imaging? In the early months in China, there were some advocates that PCR was either unavailable, or the sensitivity was too low, or the sensitivity was just unknown, and they advocated a PCR CT approach. Should we be sending all of these patients to the CT scanner? What we did, beginning in April and published in the August issue of Academic Emergency Medicine, was this scoping review of history, physical exam, labs, and imaging for COVID-19. And really what this was, because it's like building a sandcastle on the beach when the waves come in and keep washing everything away, because the evidence was coming so fast. What this really was a line in the sand. This is what quality evidence is, and this is what quality evidence is not. This is how future studies in COVID-19 diagnostics can really improve the science, improve our understanding, and probably save money and lives in the process of really refining the science. But we're going to walk you through that journey. So the first thing is I encourage our trainees to think in terms of a Bayesian physician. And that means you need to start with the pretest probability, which is really the Achilles heel of Bayesian logic. What is the pretest probability of COVID? And that's not static. You all know that we've seen a summer long, the numbers wax and wane across different states and different regions. In St. Louis, we've got a website that you can check out week to week. It shows you the positive test cases. And I checked it a couple weeks ago, I was just putting this together. And at that time, there were 35 probable cases of COVID per 100,000 residents. So that means the pretest probability at that time was 0.035% for any patient that you pick out randomly to have COVID. And when I talk about Bayesian logic, this is what I'm talking about. Fagan's nomogram, where you start with the pretest probability, and then you have the likelihood ratio of the test. And by test, I mean element of history, physical exam, labs, or imaging. And our pretest probability was well less than 0.1%. But let's say it's a number like our taxi driver, and say the prevalence is 91%. We're in the second wave of COVID. And I say that I've got a test with a positive likelihood ratio of 10. That means my post-test probability with the positive test, whatever that test is, goes from 1% to 10%. Say that test is negative, and I've got a negative likelihood ratio of 0.1. My probability then goes from 1% down to 0.1%. And that's what I want people thinking of in terms of COVID-19 diagnostics. So what did we find? Remember, this is May. We are just three or 4 months into the epidemic when it started in China, just about 2 months into the epidemic in North America. And so the literature was very sparse. It was pretty poor quality. In fact, some of it had not even undergone peer review. Some of it was just early pre-pubs that really didn't look like any editor or reviewer had looked at them. They did not have obvious peer review. They didn't adhere to the START criteria. 0 studies adhered to the START criteria, which are the Equator Network standards for how you conduct and report diagnostic research. 0 studies. So what we found was that fever was the most common symptom, 84 to 87% of COVID cases at that time. You'll note that I don't report sensitivities or specificities or likelihood ratios because they didn't report them. They didn't have 2x2 tables for me to be able to recompute likelihood ratios. What they did have was the loss of smell or the loss of taste seemed to be a pretty good test to rule in COVID. And some of the early prognostic decision aids that try to predict the course of COVID or the likelihood of COVID for accuracy, they were finding that if you didn't include loss of taste or smell, your model was really a weaker model, less able to predict whether COVID was present or not. The likelihood ratio positive 5, anything greater than 10 is a really good rule-in test. Anything less than 0.1 for a negative likelihood ratio is really good to rule out. You see these aren't very good to rule out. The absence of loss of taste or smell, not good, but the present seems pretty good based on our early research. What about routine labs? Lymphopenia, over 50% of patients had lymphopenia and you got your CBC back. And in the early days, I was hearing all kinds of chatter about other tests like LDH, a non-specific marker of lung injury, maybe as a diagnostic test, ferritin, PT, D-dimer, interleukin-6, which really isn't available as far as labs. But what we had found at that time in early May was that these were good prognostic tests for the patients that aren't going to do well with COVID, might benefit from an ICU setting, but not very good at diagnosis. What about imaging? Chest x-ray. Those early months showed that chest x-ray had a 33 to 60% sensitivity. And none of the studies really reported the training of the radiologist, the experience level, the timing of disease of the patient, how long they'd had symptoms, or reliability between radiologist reliability or reproducibility of those chest x-ray reads. Sensitivity had sensitivity substantially higher, 72 to 94%, and they did have a specificity reported. You can see a huge range of specificities, 24 to 100%. And as I mentioned before, in China, they either didn't have PCR testing or they didn't believe the results because the sensitivities were as low as 50 or 60% in those early days. So some of them were advocating you do PCR, if it's negative, you do a CT scan to make absolutely sure that this patient does not have COVID-19. Our colleagues here at WashU, Costa Raptis and Sanjay Bala, and many other radiologists published this review almost concurrently with our scoping review. And they looked critically at this recommendation for CT as an adjunct for PCR testing. And they found that all the studies were retrospective studies coming out of China. None of them really adhered to STARD, as we had said. None of them contemplated the potential harms of a widespread CT process for these patients with suspected COVID in terms of risk to the CT staff as you're moving these potential COVID patients in and out, or to the next patient that's coming, risk of COVID exposure, because there's a recommendation from the American Society of Radiology that you do this 30-minute decontamination of the CT scanner each time a patient with suspected COVID comes through. And there's no evidence showing that identifying COVID with CT that was missed by PCR really changes outcomes. It doesn't change the next decision point. In most cases, there wasn't really a therapy for COVID-19 at that time. Some could argue there still really isn't. And so there was a thought that why do the CT that really doesn't change your outcomes? And so they were pushing back a little bit in this commentary, which really mimicked our view of the literature as well. What about serology tests? At the time that we did this review, there were multiple assays that were undergoing emergency use authorization. The accuracy seemed to be time dependent, meaning the longer you wait, usually after 20 days, the more likely you are to optimize your diagnostic accuracy. Sensitivities at that time ranged 82 to 100%, specificities 87 to 100%. I'm going to get to a Cochrane review on this topic in just a minute, but the Cochrane review, just to spill the beans on that, the Cochrane review has shown sensitivities quite variable between the different serologic tests. Specificities seem to be closer to 100%, like 98 to 100%, but the sensitivities are all over the board with the different serology tests. More importantly, what the Cochrane review didn't show that we were able to demonstrate was that the prevalence in your community of COVID, again, that pretest probability, really affects how you interpret these serologic tests. And this shows you 3 different serologic tests that were available at the time that we did our review. And you can see that there, as you get to a lower prevalence, your risk of a false positive result substantially increases. And that risk is really variable across the different tests. The epitope test here, you can see at about 40 really starts to skew towards false positives. In fact, if you have a pretest probability of 10% COVID and you get a positive epitope test back, you're more likely that that's a false positive than that it's a true positive. Similarly, the false negative rates tend to really start to skyrocket as you get higher disease prevalence. Hopefully we never get to a community where we've got 80% prevalence of COVID, but if we do, we've got to bear in mind that those serologic tests are skewing towards false negatives. How exactly did we do that? That chart you just saw, that graph? Well, we manipulated Bayes' theorem to this formula where true positives equal false positives. And you can see the formula there, a function of sensitivity and specificity. And we just use the sensitivities and specificities being reported in the literature for those serologic tests. But this is important to understand when we're interpreting these tests. There is some variability across tests and across the disease prevalence in the community. So what about real-time reverse transcriptase PCR, transcription PCR? In the early days, surprisingly, since this was the gold standard that so many were using, sensitivity and specificity weren't being reported. We had to dig really hard. We even went to the FDA websites and the emergency use authorizations. They weren't being reported there either. The FDA was approving these tests without really knowing what the sensitivities and specificities were. Pool test, but what we were able to find was that there's some evidence showing pool testing. That is, we had a scant supply of materials to run some of these tests. As you will recall, we ran out sometimes. So in an effort to preserve those materials, you can do pooled specimens where you put more than one patient's serology or blood, sorry, not blood, the sample that you're running, whatever it is, for the PCR test, whether that's sputum or a nasopharyngeal. And if you do a pool test, you optimize the yield with 4 patients if the prevalence of disease is less than 10%. And we also found that the repeat testing tended to increase sensitivity. One test sensitivity was 78%. You run 2 tests on the same patient, that's 86%. 5 tests got you up to 98%, not 100%, but repeat testing was sometimes beneficial. We also were able to put together the common causes of false negatives. And I was pretty surprised in May that nobody had really published this yet. There's different hints across different publications about what were potential reasons to have a false negative PCR, but nobody had really put it into a table. And if you just work through these, they make sense. But this is the only site that I've seen still. The Cochrane review on this topic doesn't really put it into a table either. It can include laboratory handling if the lab is too warm or it's stored next to something that's causing heat. That heat inactivates the virus. There's a limit of detection. Each of the PCR assays has a different limit of detection for the RNA particles. The PCR test also tests 2 regions of the virus, and there can be mutations in those probe targets, and that test may not be able to detect when there's a mutation. The sampling procedure, that's really important in terms of the people in the studies. How did they collect the nasopharyngeal swab? How were they trained? Did anybody assess fidelity of how the nurse or the physician or the research assistant was collecting that specimen? And patient cooperation. We've all in the emergency department, we've seen these patients just pull away as soon as you get that swab near their nose. You really need to get deep into the nasopharyngeal space to have a good test. The virus replication may vary across different patients. Estimate the virus replication in different stages of disease severity. Obviously, the specimen tested probably causes some differences in the false negative rates, nasopharyngeal versus oropharyngeal versus saliva, sputum, bronchoalveolar lavage, or stool. And the test kit itself may vary by quality in the timing in the course of disease. So all of these are things that future research, when they're thinking about false negatives for PCR, should be trying to measure and report so that we can interpret those results. There's other forms of bias though, and this is where I'm going to spend the next couple minutes of the lecture. And I want people to take these lessons, not just for COVID, but this applies to anything diagnostic, these different biases I'm going to talk about, 5 different types. So partial verification bias means that a finding makes you more likely to get the gold standard test. The absence of that finding makes you less likely to get the gold standard. This citation here is a paper where we actually took examples from literature and showed you mathematically how this skews sensitivity and specificity. In this case, CT heads for headache. In the 1980s, CT scans were pretty new. It was really hard to get a CT scan. I remember from my med school days in Detroit, it was a big ordeal to get the patient up to, I think it was a 5th floor in the emergency department, was on the 1st floor, up to the CT scanner to do a head CT. So you didn't want to get a CT unless you absolutely had to. And so you're more likely in a patient who has a headache and you believe that headache is a marker of hemorrhagic stroke to get a CT scan on that patient. That likelihood of getting the CT scan for hemorrhage means that if you look at sensitivity and specificity, sensitivity is the disease positive patients, and that sensitivity is the proportion of those with disease who have a positive test. Specificity is the disease negative patients, and specificity is the proportion of patients who don't have disease who have a negative test. And you see that you get proportionally more patients taken out of the numerator of specificity, and you reduce the denominator for sensitivity. So you increase sensitivity and decrease specificity. And mathematically, we show you how that happens. In COVID, this can happen if you've got a patient who has all the classic COVID symptoms, is more likely to get a PCR test than a patient who comes in saying, my neighbor had COVID, I'm worried that I have it. You don't test that patient. So partial verification, one patient gets the PCR, the other doesn't. Differential verification bias is a little bit different. That is that there's 2 gold standards, that any given patient may have a different assessment for whether disease is present or absent. In this case, we use an example of elbow extension test. Patients come in with an elbow injury, they're worried about an elbow fracture, and if they can extend their arm, the thought is that they're less likely to have a fracture. The gold standard in this study was X-ray. But what they found was that very few of the patients who had a negative elbow extension test, meaning they can do it, got an X-ray. And you can see here with this modified 2x2 table that all the 6 patients who would have who didn't have an X-ray done move over to specificity and are taken out of the denominator for sensitivity. So sensitivity increases and specificity increases. Differential verification bias might occur when a patient comes in with patchy opacifications and hypoxia and high prevalence of COVID in the area. So you're really worried about COVID in this patient. They're being intubated. And so they get a gold standard of bronchoalveolar lavage PCR plus a CT scan plus probably serial PCR test if that person is negative, versus the patient who comes in without any of those symptoms and gets discharged home. Their gold standard might be clinical follow-up with no PCR. So 2 different gold standards trying to assess whether COVID is present or not. Imperfect gold standard bias. This occurs when you don't really have a true gold standard. And the example we use here is pertussis. And cultures for pertussis, versus a PCR for Pretest. And cultures are not very good for finding Pretest. And so you find that when you actually use Pretest culture as a gold standard against PCR, you get sensitivity that's falsely increased and specificity that's falsely decreased. I don't think there's any argument that we still are struggling to find a good gold standard for COVID. And in our article, what we did was proposed what we felt was a better gold standard. And still, I'm very surprised that the COVID diagnostic literature really has not clearly stated this gold standard either, not necessarily our gold standard, but a better gold standard than simply PCR. Our proposal was that you should look back weeks or months after the suspicion of COVID, look at the exposure history, the symptoms the patient came in with or developed thereafter, the laboratory tests in congregate, the PCR test for sure, imaging findings, both at that point in time and maybe in follow-up, serology testing, and viral cultures. And that composite of COVID present or absent is probably a better standard than just a single PCR, which the bulk of the studies were used in early May. Spectrum bias is the last one that I'm going to talk about. And it's not truly a bias, it's really a spectrum effect because it's not erroneous, the estimate of sensitivity and specificity you get. It's just that it's accurate for the population that you do in the research, but that's not the population you apply it to in real life. So in this case, we used an example of disease severity and acute heart failure. Some patients who come in with acute undifferentiated dyspnea and CHF is differential along with COPD or venous thromboembolism or pneumonia or pneumothorax maybe. Some of those patients have left ventricular dysfunction, but they're not having acute heart failure. And if you take out those who have left ventricular dysfunction, but it's not acute heart failure causing their dyspnea today, you actually leave the sensitivity unchanged because that sensitivity column doesn't change at all, but specificity is falsely increased. So you artificially see a higher specificity when you apply that same test. In this case, I think it was a BNP test in the real world population. So that's one form of spectrum bias. Another form of spectrum bias is ambiguous results. And you recall that I said the PCR test tests different regions of the virus. And in most of the reports in PCR, even to this day, they don't really tell you how they deal with those ambiguous results in reporting their sensitivity and specificity. One way to do it is with a 3x2 table. You lump those ambiguous results in the middle. We've done a couple of our diagnostic studies. But if you don't account for those ambiguous results, if you just throw them out and report the ones that aren't ambiguous, you see that you've artificially increased sensitivity and artificially increased specificity compared to using this tool in the real world. So the constellation of all of those biases, I think, helps us both with COVID and with other diagnostic issues that we face to really understand how to dive into that research and dissect it. So how do we pull this together now? Well, one approach that I advocate is shared decision-making with patients. I had the pleasure in 2016 of leading a consensus conference at the Society for Academic Emergency Medicine on shared decision-making to really understand the state of the literature in 2016 and a high-yield research path moving forward. I'm a big advocate for shared decision-making, which I really think is in its infancy in terms of how we do this. We proposed a very elementary shared decision-making instrument in our article for COVID-19 and PCR. And this basically looked at sensitivities ranging from 60% to 80% and tried to formulate a handout that we could give patients of all health literacy so that they could understand the level of uncertainty we had interpreting that test result. And this is one form of shared decision-making that could be done. The same could be done for X-ray or clinical presentation or CT scanning if you choose to go that way, or serology. So I really had limited amount of time to really dig into my passion of these diagnostic biases here today. We did a podcast on this very topic and I was able to dive into the diagnostic biases a bit more firmly. If you want to, you can access that podcast here. It's about 30 minutes long. And 2 months after our scoping review came out, Cochrane came out with signs and symptoms to determine if a patient presenting in primary care hospital settings has COVID. Their findings are a bit more disappointing than ours. They really aren't big fans of smell or taste disorders. They didn't include some of the studies that we included, and their sensitivities dropped down to in the 20%, I think, for loss of smell or taste disorders. Again, they really didn't dive into the biases the way that we did, nor did they propose an alternative gold standard, but they did share our concerns that the quality of the peer review was lacking, even as late as July when they published theirs. and the STAR criteria do not appear to be being used to report quality research. They've also most recently published a systematic review on point of care antigen and molecular based testing as well. So what I want to leave you with is we've got some resources that we've published over the years. This is at the Becker Medical Library that you can download for free. This is the second edition that takes common emergency scenarios and gives you the sensitivity, specificities, and likelihood ratios for history, physical exam labs, and imaging for those conditions. We're working on the third edition now. We also created a series of peer-reviewed articles at Academic Emergency Medicine to explore diagnostic issues, which are with septic arthritis, and have since published a constellation of over 25 articles now. And the beauty of these articles is we don't stop at dichotomous likelihood ratios, but also get into interval likelihood ratios for continuous data like PCR. And we also have this concept called the test treatment threshold, which really helps us to theoretically identify populations most likely to benefit. So check out this series and consider contributing to it if you'd like. So I'm going to turn the stage over to Dr. Mudd now, who's going to really talk about his research in immunology and applications to potential treatments for COVID. Dr. Mudd.
Thank you, Dr. Carpenter. I'm just going to start with disclosures once again. So I really have no relevant relationships to disclose. I do receive a little bit of research support, which I outline here. Just of interest, I do have a patent application that I'm a listed co-inventor on that's entitled Targeting Modulation of the Inflammatory Cascade in Patients with Severe Viral Respiratory Illness. That may be relevant to the talk. My wife is employed by a drug company, but I personally own no stocks or equity in any pharmaceuticals. So I'm going to go into the second portion of our lecture objectives, which is to talk about understanding the frequency of cytokine storm in severe COVID-19, and also a discussion of mortality reduction and how that may mechanistically be happening, at least our hypothesis in patients that do have severe COVID-19. So we'll start once again with another scenario, just to kind of make this a little more clinically relevant. So you have a 91-year-old retiree coming in from a long-term care facility who's had a cough. They have a history of dementia and hypertension. The vitals are, as you see them there, notable for that 87% pulse oxygenation on 2 liters of nasal cannula oxygen. They have some cough and they have rhonchorous lung fields on exam. Their chest x-ray comes back with multifocal infiltrates. So what do you do for this patient? Well, there's a lot of things that need to happen for this patient, especially in our emergency department environment downstairs. We're going to start obviously by trying to increase oxygen delivery to this person. They do have a history of dementia, but obviously goals of care discussions that try to include the patient as much as possible, but also the patient's family. Certainly there's other things that could be going on in this individual. Multifocal pneumonia is not new to COVID-19, although it's probably the thing we're seeing the most right now. Remdesivir, the evidence for that is not grand, but there's some evidence, so certainly trying that. Dexamethasone, which everybody's been hearing about and talking about. I think the points I want to get to with my portion of the lecture is what are we actually treating dexamethasone, and are we treating anything? Everybody had started the COVID-19 pandemic talking about cytokine storm in patients with severe COVID-19. Does this patient have cytokine storm? Is that what we're treating with the dexamethasone? And the research that I undertook that I'll present here today is kind of trying to differentiate that to some degree. And if this patient does have cytokine storm, can we reliably identify that cytokine storm in patients with our current technology, the lab tests that we're actually doing in the hospital here? So we started a biospecimen repository essentially as we got our first patients with COVID-19 here at Barnes-Jewish Hospital. Jane O'Halloran and infectious diseases and myself kind of put this together. We had funding from the Barnes-Jewish Hospital Foundation. It involved a major cross-institutional collaboration that was kind of coordinated by the ICTS with the involvement of many different groups on campus, including the Emergency Care Research Corps and the ID Clinical Research Unit and the Siteman Tissue Procurement Corps, which processed a lot of the samples for this. We just ended enrollment at the end of September. We had a total of 500 subjects that we enrolled into this study. I'm just going to put some statistics out about the patients that we have in the study that was done here. It's about 46% female. We enrolled most of the patients at Barnstable Hospital. There was a small subset that was enrolled in the outpatient respiratory clinics. A large number of the negatives were there because those were folks that were sent in for concern for COVID-19 but didn't require hospitalization. And there was a whole range of things that those folks came in with. We did start enrollment at Christian Hospital towards the end of the study, and we ended up having about 10% of our patients being hospitalized patients at Christian Hospital. In some of this, 79% of the patients were positive for SARS-CoV-2. And the reason why there's a fall off there is because it's difficult to enroll in studies like this because you're trying to encompass everybody that may have this, including outpatient illness. And some of those folks are just not going to have a positive test. Some of the patients in the outpatient clinic actually didn't even have a test sent because they didn't ultimately have symptoms concerning for COVID-19. And furthermore, false negatives are also a possibility for several of these individuals. So the study I wanted to undertake was to see what is going on with cytokine storm. Does it exist like everybody said it did in the popular media? I'm an influenza researcher. That was my background here for the past 3 years that I've worked here. So I kind of transitioned from collecting biospecimens on influenza patients, and we have influenza cohort of more than 105 patients that we've enrolled just in my time here in the last 2 or 3 years. We actually had 26 that were enrolled in the previous flu season. And we started to develop from the early samples in this cohort to measure cytokines and see if these individuals with COVID-19 had cytokine storm when compared to seasonal influenza patients who are not generally thought to have cytokine storm as a source of their respiratory failure. We also had some healthy control subjects, which were healthy flu vaccine study patients that were provided by Ali El-Abedi in pathology immunology, who was one of the collaborators on this study. This is a large, busy table. I don't expect you to know all of the information in this table, but I'm going to draw your attention to a few things. So we have patients in the primary cohort. So that was the first enrolled subjects in the WashU 350 study that were SARS-CoV-2 positive. Here's the influenza cohort and our healthy control cohort. So one of the most notable things is that there was a significant difference in age. We did a multivariable logistic regression analysis to try to control for as many of these variables, both demographic and clinical characteristics that we could. And when analyzing all of these things, age was still statistically different between the SARS-CoV-2 patients and the flu patients that we were comparing. I'm going to bring your attention also to the frequency in this first portion of the WashU 350 study patients. These patients were actually enrolled in end of March and throughout April, with the second cohort mostly in May and early June. But the first portion of these patients had a really high frequency of intubation and mechanical ventilation. As you'll recall, this was when we were directed to intubate everybody early. If you required more than 6 liters of oxygen, you needed to have an endotracheal tube, is what we were told. We also had a really high in-hospital mortality in these folks. It wasn't statistically different from the mortality in our flu patients, but it was 30% in this early portion of the cohort. So keeping in mind those numbers, the 44% and 30%, the second portion of the cohort, the subjects that were enrolled in May and into June, had much lower frequencies of intubation and mechanical ventilation because the guidance had changed at that point in time. And interestingly, our in-hospital death went from 30% to 17%, which was not statistically significant in our logistic regression model. But the frequency of intubation and mechanical ventilation was actually significantly decreased in the second portion of the cohort that were SARS-CoV-2 PCR positive. Other things to note is that this validation cohort that we were looking at cytokines in also had a significantly increased age compared to the flu cohort that we were studying. And the only other difference was that there was actually less chronic lung disease in the later portions of the cohort. There was no difference between the flu cohort and the SARS-CoV-2 cohort. In the primary individuals, there is a high frequency of individuals that have chronic lung disease that get really sick in both of those conditions, although that has decreased as the pandemic has gone along, is that we're getting more folks that don't have chronic respiratory disease that are just getting COVID-19 that generally is being hospitalized. Most of these patients in our cohort were hospitalized. This is just an aside. This has nothing to do with cytokines, but this is something we found and we reported in the publication that we're putting together that's in bioRxiv right now. I'm sorry, medRxiv right now. But there was definitely a negative correlation with the percentage of patients that we intubated and time as we went along, which makes sense because the guidance had changed. We were supposed to intubate people less as we were optimizing oxygen delivery as we went along. But it's interesting to me, at least, that it correlated with this increase in mortality on a week-to-week basis. So the patients who survived increased as we went along, as we started to decrease the number of patients we intubated. I think there's definitely a signal in our data that there is probably harm from this early intubation strategy that we undertook at the beginning of this pandemic. We don't really have the ability with this small data set to control for all the different variables in this, but I think it's something that certainly needs to be studied in the future. So how did we actually physically measure the cytokines? We used a multiplexed assay, which is a bead-based assay. This is kind of an overview of the technology. It's called the Luminex Platform. It's basically an ELISA, sandwich ELISA on a couple of beads that have fluorophores. And using that, you can actually detect, using a laser, the amount of fluorescence and therefore the amount of the analyte of the cytokine that's in a solution. You can actually do 35 different cytokines in one well, which was the multiplexed assay that we used to measure this. It's a technology that's been around for at least 2 decades now, and it's very good technology, and this is what we did. So the results that we saw was that there's really actually less cytokines circulating in patients with seasonal influenza when compared to COVID-19. So this is a plot where we normalized each of the individual cytokines that we measured the concentration of to the amount in the seasonal flu cohort, and then compared the difference to that normalized value with the COVID-19 patients. And there were, for 28 of the 35 cytokines, there's actually less of the cytokines circulating in the seasonal flu cohort. And all of the ones that were positively or higher in COVID-19, VEGF, NCP1, IP10, IL-8, IL-6, HGF, and EGF, none of those were actually significantly different when we controlled for all the different covariates, age, everything in our estimated marginal means analysis. Interestingly, though, there was a subset of individuals. This is a PCA analysis of all of the different cytokines and all of the different patients. The primary cohort is on top. The validation cohort is on the bottom. There was actually a small group of patients, 3 in the primary cohort and 4 that you can see here in the validation cohort, that segregated in a different location on the principal component analysis, suggesting they had significantly different cytokine expression with upregulation of a vast number of the 35 cytokines. There was only a couple of the cytokines that were not drivers, major drivers of this change, interferon gamma or antis being a few of the ones that were not changed substantially. But these individuals actually did have a large number of significantly different cytokines from the main cohort, which we define these individuals as cytokine storm patients. There were 3 in the primary cohort and 4 in the validation cohort. This PCA analysis also revealed that we had this small subset of signature that we called a Th22 signature because many of the cytokines were associated with the Th22 type response. We didn't really include those as stormers because it was a unique subset of just a handful, half dozen or so of the cytokines. But nevertheless, we are seeing cytokine storm in our cohort. Is kind of the take home from this. It's just a very low frequency. We've found a total of 7 of our 182. So can you identify these patients with cytokine storm with the lab tests that we've sent to all these patients? And we have data in the 350 cohort for lab tests that were sent on each of these subjects within 24 hours of when our samples were drawn. So within 24 hours of when our cytokine samples were drawn, we compared all of the lab tests that were actually performed on these individuals. And obviously not all of them got a ferritin within 24 hours of the sample. But there was actually no differences that we could see between the cytokine storm patients and the non-cytokine storm patients for any of our measured laboratory tests on these individuals. It was 7 of 162 patients had the cytokine storm. All 7 of them were admitted to the hospital. 4 of the 7 were admitted to the ICU, intubated, and actually died. So there is a very high frequency of mortality in these individuals that do have cytokine storm compared to others. The other inverse of this is that there's 30% in our primary cohort that are dying, and only 3 of those had cytokine storm. So the vast majority of people with fatal COVID-19 are not exhibiting evidence of cytokine storm. These are the individual measured cytokines with the statistical analysis. This is just going to point out that IL-6 and IL-8, two of the cytokines that everybody's talked about that are elevated in patients with severe COVID-19, which is true, are not significantly elevated when compared to the cohort of flu patients. The primary cohort cytokine storm patients in the validation are here. They generally have higher values of these cytokines as well. But as I'll point out here, that most of the cytokines were lower in the COVID-19 patients compared to the influenza cohort. And TNF alpha and interferon gamma, others that have been said as being important in COVID-19 immunopathology, were actually less, significantly less than what you see in patients with seasonal influenza. We're not the first to report on this. There was a paper published in JAMA in September. Our preprint was before this, but the group that published this in September looked at various cohorts and certain cytokines, specifically TNF, IL-6, and IL-8, some of those that have been said to be important in immunopathogenesis of COVID-19. And they've basically shown that COVID-19 with the ARDS patients had lower values of IL-6, IL-8, and TNF alpha compared to septic patients with ARDS, even sometimes septic patients with no ARDS, out of hospital cardiac arrest, and trauma patients. So in general, these things that everybody's saying, cytokine storm, IL-6, IL-8, most COVID-19 patients with ARDS actually don't have that much more IL-6, IL-8, TNF alpha than other critically ill patients with ARDS. So just to summarize, COVID-19 patients, as we've mentioned, generally have lower circulating cytokine concentrations than seasonal flu patients. Fatal COVID-19 is not frequently associated with cytokine storm. There's only about 5% of the patients that meet criteria for cytokine storm in our hospitalized cohort. And they have really high mortality, but you can't easily figure out who they are just based on our current lab tests. We did recapitulate some of the findings that have been found with the severity of illness that people have reported with increased of certain cytokines in COVID-19. So if you look at all COVID-19 patients, there is an association, an increased odds ratio of death and ICU admission in individuals with high IL-6 concentrations, high IL-8 concentrations, high IL-1 receptor antagonist concentrations. Nevertheless, these are not necessarily a storm in these cases. They just have higher values than other patients with COVID-19. So there still may be utility in determining prognosis based on these markers, but it doesn't necessarily correlate with whether or not they have cytokine storm. So why do I think this is important related to treatment? And this is hypothesis, but I'm going to go over the data from the recovery trial, which measured dexamethasone treatment in patients that were hospitalized with COVID-19. They demonstrated that there was a reduction in mortality in folks who had gotten dexamethasone compared to usual care at day 28 following randomization. The largest effect size was in mechanically ventilated patients. I think everybody's pretty familiar with this. There was an effect, though, that was statistically significant in patients that required oxygen, supplemental oxygen at any time during their hospitalization, although the effect size was lower. And individuals that were hospitalized with COVID-19 but did not need oxygen, there was actually a trend towards harm with dexamethasone, which is why we are cautious with dexamethasone in patients that are hospitalized but don't require oxygen. I'm going to go over the individual numbers and kind of point to why I think this might be related to cytokine storm. So if you look at the numbers of patients and the differences in the recovery trial, there was about 22.9% mortality on the patients that had dexamethasone and 25.7% mortality in the usual care subjects. That's the total cohort. So if you calculate it out in absolute risk reduction, that's about 2.8% of their hospitalized patients that were saved by dexamethasone, which is a number needed to treat of 35 if you're doing the numbers there. If you look at just the mechanically ventilated cohort, that was a 12.1% absolute risk reduction in those individuals. And I posit that may actually be because they are treating patients with cytokine storm. It's kind of a blunt instrument to treat all of these individuals since you can't figure out which ones actually have cytokine storm. But what we see in our total hospitalized cohort is that about 4.3% of those individuals have cytokine storm, which is on par with the 2.8% that they had in their absolute risk reduction for mortality in their total hospitalized cohort. In our mechanically ventilated cohort, it was about 7.1% of those individuals had cytokine storm, which is close to the 12.1. But if you look at the recent meta-analysis that was published in JAMA by the World Health Organization group, that mostly relied upon the recovery trial, but there were other small steroid studies that they put in together for that meta-analysis. They found an absolute risk reduction of 8.7% for mortality in mechanically ventilated patients that receive steroids, which is much more on par with our 7.1% frequency of cytokine storm. So I'm just going to summarize. Steroid treatment is important in individuals with COVID-19 who require oxygen. Dexamethasone is the most studied. You have about an 8 to 12% mortality reduction. You can potentially harm patients that you're giving steroids to that don't require oxygen for COVID-19. We have some other data, which I didn't present, that cortisol levels in all patients with COVID-19 and flu patients, frankly, are higher than baseline cortisol concentrations in healthy controls. There's a lot of caveats to that, which is why we haven't presented that or gone further with that. But I don't think there's a lack of cortisol or general intrinsic steroids in these individuals in general, which is probably why there may be even harm in patients that aren't requiring oxygen. So I think if you target your dexamethasone to the right population, I think that's where you're going to get the most benefit. So I think we're just going to say thank you at this point in time, and then we can open this up to questions or any questions that are here. Maybe go grab my mask and Chris can come up as well.
Thank you, Dr. Carpenter and Dr. Mudd. We are going to move into the question and answer section at this point. So feel free to use this Q&A tool. We have one question that came up in relation to Dr. Mudd's portion. So what time point was used to measure the cytokines in the W350 cohort? Is there utility in measuring the levels over a time course?
Yeah, so the time point that we looked at was the initial blood draw sample, which was typically done as soon as the research team had access to the patient and was pretty sure that they had COVID-19. We were trying to select for patients to make that 79% of our cohort be positive. We were really trying to select for patients that were going to be positive. So that was usually within a day to 2 days of hospitalization, depending on how long the tests were taking at that point in time. But it tended to be very early samples in the patient's course in the hospital. So our idea with that was that would be the most relevant time for prognostication as opposed to over time. Certainly there are changes over time. I've looked at some of the cytokines over time. In the individuals who have a fatal outcome with COVID-19 that are in the ICU, there tends to be pretty steep increases in IL-6. Things keep going up. Apart from IL-6 though, there's not a lot of others that change over time to a significant degree. But IL-6 does appear to have a significant increasing trajectory in individuals that have a bad outcome. So there may be utility in measuring that over time in certain patients.
Next question is for Dr. Carpenter. I found it interesting that shared decision-making tool that could be used to talk to patients about the different sensitivities and specificities of the testing we have available. Is that utilized in our emergency department? And if so, how has the patient outcomes or the patient response to that been?
Thank you for the question. No, I don't think it's routinely used in our emergency department or any emergency department. I use it when I get PCRs on patients and they would like me to explain the results to them about how to interpret it. It really, there is a science to shared decision-making in developing the instruments and testing the instruments. The best science we have thus far is on chest pain decision aid to help patients interpret their ED visit, the symptoms they came in with, and the value or lack thereof of further testing like a stress test. And that went through multiple iterations and testing on different patient populations to determine whether it increased patient understanding of the choices. It was able to help them incorporate their values into the decision-making and better understand what their prognosis is. We've not done any of that with COVID, but I think there's certainly an opportunity to do that.
Great. The next question here is, why wasn't an early intubation strategy at 5 to 6 liters oxygen pursued at first? Was there strong evidence for this based on ARDS analogy or early Chinese medical team reports?
Well, so the question is, why was it not?
Why was there an early intubation strategy previously, earlier when we were learning about COVID at first?
I'm not completely sure. I think the thought was infection control, that there would be, you could contain things more in a circuit and with a HEPA filtration system in that circuit. I always kind of wondered why we were doing that. And I wasn't a strong advocate for that necessarily. So I don't have any good insights into why that was pursued. I think our data suggests that there was harm to that. I think there could be larger data sets that could be studied that could show if that is true or not. But I think it probably was not a good idea.
Okay, and probably the last question here, is there any utility in pulse dose steroids for the critically ill ventilated patients who may have cytokine storm?
Yeah, I think my take home I wanted to have was that there needs to be a better test to identify these individuals. And certainly I think pulse dosing for those individuals that do have cytokine storm might be helpful. I think the bigger issue is that we need to make sure that folks that are critically ill, which have a high mortality, and there's a higher frequency of cytokine storm, those individuals are getting the appropriate treatment. So making sure everybody is getting dexamethasone. Whether pulse dosing shuts down cytokine storm better than a single Q-day dosing, I don't know that that's been studied in viral respiratory illnesses. I know there's been some studies in avian influenza looking at steroid treatment in China, but I'm not aware of any others that look at it in viral respiratory illnesses. There may be more data though in sepsis and other forms of ARDS that I'm not aware of.
Okay, I think that concludes Grand Rounds this morning. Thank you everyone for joining us on Zoom. And thank you, Dr. Carpenter and Dr. Mudd, for coming here and joining us for Internal Medicine Grand Rounds. I'll go ahead and share my screen so people can get QR codes.